Hi, my name is Emily Olson. I'm senior editor for Moby Health News, and I'm here for HIMSS TV interview. So what do you think is going on particularly right now, big innovations that you want to talk about you're really interested in?
What happened with COVID-19 is that we've had a lot of changes that we as an industry have experienced. Change both in terms of patient care, change both in terms of how we respond to a pandemic, and change in how we use technology to meet that response. So that's where we have seen a lot of change in how we've done things. And we think the change is going to stay. And the reason why it's going to stay is because we've just another second round or third round, whatever you want to call it, right? So we think that there is opportunity for us to leverage this change and transform the healthcare industry to a more robust technology-based capability that we can get to. The olden days of, we've got inpatient, there's ambulatory, there's different care settings, and when you look at those care settings, the patient ins and out these care settings, and that's what typically happens with patient. Now, in the new world, when a patient doesn't have to come into a physician's office, or doesn't have to get checked into a hospital for care for the next 3 days to 10 days, it's a very different environment. Like, for example, in an ambulatory surgery center today, where we check in a patient for surgery at 4 a.m. in the morning, and he's discharged by 11 o'clock at night for a very complex surgery, like a hip replacement to get done. So when you get into that mode, you go into an acute kind of facility only when you really need to. Otherwise, you don't have to be there. And people at some point in time will say, "What's this hospital you're talking about? It's just a building that I get to care and get back home." That's what's happening. And when you look at where we are today from that mindset, we're getting there. We're looking at solutions like hospital at home. Patients who have high acute are only in the hospital. The rest, the people who have low acute, are typically discharged, either discharged earlier from the hospital to go recuperate at home, because now they have got the vitals that they can come through remote patient monitoring, capabilities like that. So the world is transitioning, the world is changing. We just believe that we are at a precipice of that change to happen. And from our perspective, from an innovation perspective, that is where we think we will be making our investments as an industry.
Yeah. So pre-COVID-19, certainly people used telehealth, hospital at home existed, and obviously it's really accelerating post-pandemic.
Yeah.
Would you say that you think people trust the quality of care that's coming out of telehealth or hospital at home programs more post-pandemic? Do you think that sort of trust in the quality is there now?
Sure, definitely. If you take a look at where we were today, pre-pandemic, right? Pre-pandemic, it was more about a fancy thing to do, right? Telemedicine was like really fancy. They thought it was a lot of expense. It was only those cool people who did telemedicine, right? And there are some hospitals where like, oh well, that's a great thing to try out, right? While with pandemic, there's no try out. That became your mechanism to deliver care. So we had a situation where, and several organizations were similar, we had sent our employees home to work from home. We had to make sure that we were still getting the revenue in from a care perspective. We still had to care for our patients who were in the middle of their care plans. So we had to very quickly shift to a telemedicine type of environment. And we had probably, if I take a look at it, about 3 to 4 video visits or telemedicine visits a day to thousands in a week, right, across the system. So it's huge. It's phenomenal, and that's the kind of change you're talking about. And we were forced to change, whereas now we have the opportunity to say, well, you don't want to be forced to change. Let us help you with the change.
And how do you find providers and maybe your office support staff are kind of getting used to a remote environment, both from a provider perspective for telehealth as well for some of those in-office support staff who maybe now are working from home for the first time in their careers?
So for the first time, we were able to see patients who were in the hospital remotely by a physician from home. That has not happened in the industry. If I had told you that 3 years ago, you'd be like, "Are you kidding me? That's not going to happen," because physicians were expected to be in the hospital and take care of that patient. Similarly, on the physician's office side, the MA or the person in registration was supposed to be in front of you in order to gather your information. Otherwise, they'd be like, "Wait a minute, I can't operate this way." All of that transformed. They have now realized that they could do work from home in the sense that you could do remote check-in. Right? I can remotely check you in as a patient. I could supply you with my vitals information if I have the gadget with me, the devices with me. And I could prep the physician with all the information so that when the physician comes into the video visit, he has got all the information he needs inside his own EMR. That's the other transition that we got to. A lot more comfort right now compared to where it was about 2.5 years ago, 2 years ago. And then a lot more flexibility associated with it as well. So that's where I think we got a big change happening.
You mentioned flexibility. Do you find that patients and providers are really getting used to that flexibility and do they like it? Do they think that's something that actually makes care a little better?
You got both camps. Some people are like, well, I want to get my patients back in my office. And there are patients who are like, I better see my physician in the office rather than see him through a video visit. And on the other hand side, you're like, I don't want to go to the office. I can just, I'm at work. I can just see the physician from my phone. Let me have that conversation. And the physicians are like, well, I've got 20 minutes to squeeze another patient in. Can I do a video visit? Right? So you got those capabilities that we've now delivered. So you could have, and we have some practices that have transitioned from full-time in-person visit to some in-person, some video visit during the day with the specific providers. So if I have to have a cardiology visit, and it's not the first time visit obviously, but a repeat visit, I can just go have a conversation with the cardiologist and go, hey, here's my readings, here's what's going on, change of medications, go to Walgreens, pick up a medication, I'm done, right? For the next 3 months, I don't have to see a cardiologist. That's the kind of transition we are seeing right now. What we expect to see is that full-scale transition to a more, what you call, complete telemedicine model, which is not there yet. It will get there, and it's a question of timing. It'll get there. It's something that we see that could be happening even in organizations that were not as progressive. They've now made the investments. They can now utilize the investments. That's the difference.
And one other thing I was thinking about in terms of telehealth and telemedicine, how do you bridge the gaps for health disparities, for instance, people who might not have access to high-speed internet? Is that something that you guys are considering or thinking about?
Well, we've done that too. So I'll give you a classic example. A patient didn't have high-speed internet in the house. He was like, look, I gotta come to the grocery store anyways. So I'll come to the grocery store, right? Okay, great. Why don't you swing by? I don't want to see a physician in the office. I don't want to get contaminated, all that stuff. So he came into the parking lot. We gave him an iPad. He had a video visit. He went back home within a matter of half an hour. That we would not have ever imagined in the healthcare industry. It happened with one of our patients. He came to the parking lot. The MA registered him through an iPad in the car. So he had the iPad in the car. He had a visit with the physician inside the office. He never walked in. He never saw anybody. Everything was done through the iPad, but we made it happen. So these are the kind of transformational tweaks that we're doing to the organizational elements of how the workflow is really being changed by what the physician really wants to do, what the patient wants to do, and how the care is being delivered.
Gotcha. And I guess for my final question, there's a lot of discussion about payment parity. How will we pay for telehealth? Should it be the same amount as we would pay for an in-person visit? What have you guys been thinking about in that space?
So we believe that the payments, the waivers and the payments that we've got today will continue for the foreseeable future. That's one thing. The second thing is it will get tweaked as people learn more and more. Evidence-based, that's what typically we all rely on in healthcare. Once that happens, then we will be able to make it more mainstream. It will become part of the way we operate, right? So we always had this $49 televisit, kind of capability. That's not new to us. But now, if it is your own physician doing it rather than going through another urgent care or another third-party provider, that's the difference. So that's where we get the benefit. So it will stay. We expect it to improve and deliver better care for the patients.
Well, thank you so much for talking with me today.
Thank you so much. Really appreciate it.